Andrea.
Hi, good morning. Thank you very much for the invitation. So when I first looked at this title, I thought it was a no-brainer, and I can just say FDA approval and be done. But we'll take a look at the data and discuss this in a little bit more detail. So I'm arguing pro TAS102 and Regorafenib in the salvage setting for MSS tumors. So as I mentioned, they're the only approved agents in refractory MSS metastatic colorectal cancer. Obviously, MSI high, hypermutated tumors are a different story, and there we can utilize immunotherapy, which is now FDA approved and part of the NCCN guidelines. But let's take a look at the Regorafenib data. So Regorafenib, as everyone is well aware, is an oral multikinase inhibitor targeting several pathways. The study that really brought Regorafenib to the forefront was the CORRECT study led by Dr. Grothy, in which patients with refractory metastatic colon cancer that had been treated with all standard therapies were randomized to either Rego and best supportive care versus placebo. And the eligibility criteria were very standard. And the study met its primary endpoint, which was overall survival. So there was a statistically significant benefit in overall survival of 6.4 versus 5 months in the placebo group. Taking a closer look in terms of overall response, the response rate was low. However, there was a decent disease stabilization of about 43%. The adverse events we're all very familiar with, largely hand-foot, fatigue, hypertension, and diarrhea. And these were not insignificant, but a lot has been done now in terms of learning how to use the drug better. Recently, data were published on lower dosing, which actually enables much better tolerability of the drug without compromising the efficacy. So overall, summary met its primary endpoint, overall survival by 1.4 months. PFS was not significantly different, and again, the main efficacy really seemed to be with disease control. So looking at TAS102, it's an oral combination therapy of FDT and TPI, essentially incorporating into the DNA with the TPI enabling better bioavailability of the drug. So the study that brought TAS102 onto the forefront, really very similar to the CORRECT study, the RECOURSE study, evaluating patients who had progressed on all standard therapies, metastatic colon cancer, randomized to either TAS102 or placebo in a 2-to-1 fashion. And here the primary endpoint was also overall survival, with the secondary endpoints being PFS, safety, tolerability, et cetera. So once again here we see that overall survival was statistically significant. There was a clear benefit, 7.1 versus 5.3 months. Again, PFS not significantly improved with the drug. Looking at the subgroup, the patients that previously received Regorafenib did benefit from TAS102, so this sometimes comes up in terms of sequencing. In the refractory setting, we have these two drugs. How do we use them? Again, these are very, very small numbers, but they did see that the patients who previously received Rego did benefit from TAS102. Adverse events we're also familiar with this drug, nausea, decreased blood counts, neutropenia, and fatigue. So again, really not to belabor the point of toxicity, but it's familiar, and pretty easy to manage. Looking at the two drugs, the CONCUR study that evaluated Regorafenib in the Asian population, but really overall kind of similar profile and mostly benefit in overall survival. So this is why the drugs were approved in refractory colon cancer. So what about immunotherapy in microsatellite stable metastatic colorectal cancer, which of course comprises about 98% of our stage 4 patients? So the initial trials that were done that were not selected before the MSI story was clear really showed absolutely no benefit. So you could see just essentially 0 responses down the line. So clearly there was no benefit, but was there actually any harm to single agent PD-1 inhibition? So if we take a look at the study led by Dr. Lee and Dr. Diaz, which really demonstrated a benefit in MSI high tumors, let's take a peek at the patients who were mismatch repair protein proficient, or MSS, on this study. So those are kind of obvious here clearly with the red bars showing clear progression with Keytruda pembrolizumab alone. Sorry, I don't. And then taking another look at the biochemical response. So the red lines represent, again, the MSS tumor. So this is a really significant doubling. If you look at the timing, within 2 weeks, there was significant elevation in CEA, perhaps showing that the disease might have become more aggressive on this therapy. Looking at the overall responses in the MSS group, with regard to disease control, because this really seemed to be the main bulk of the benefit with our approved agents, only 11% disease control with single agent pembrolizumab. So really not great. And again here, clear distinct difference between the MSS tumors and the MSI high tumors with regard to progression-free survival as well as overall survival. So looking at the numbers, PFS 2.2 months and overall survival about 5 months, which, as you recall, was about the placebo arm in both of the studies, specifically the correct study. And then the toxicity, we talk a lot about the toxicity of our standard agents, but it's important to remember that immunotherapy is also not without toxicity. Just because our patients feel well when they receive it, there is a significant incidence of rash, autoimmune disorders such as thyroiditis. In this study, we saw 10% and 15% pancreatitis, but we do see about 10 to 15% of autoimmune colitis as well. So the new strategies, which my opponent will focus on, and I think are important but not yet approved, are strategies to turn these cold MSS tumors into hot or immunogenic tumors. And these comprise really combination approaches of trying to kind of wake up the immune system. So one such important study is the Phase B study, which was the updated results were presented by Dr. Bendel at GI ASCO in January, where patients with refractory metastatic colon cancer were randomized to, or rather received atezo in combination with cobimetinib. And here, 7 patients, or 8%, did have a PR. And this is interesting. When the study was first presented, it seemed that the PR rate was actually much higher, but as the expansion went on, it really decreased down to 8%. And of these, 4 had confirmed MSS tumors, 1 had MSI low, and then the other 2 were unknown. So really unclear that there's truly an 8% benefit in our pure MSS population. And the disease control here was 31%. So not bad, but not great. And the PFS really not much different, about 2.5 months in the MSS group. So there are data that suggest a hint of activity in combination therapies. I think the important one to come will be the Phase 3 study in which patients were randomized to atezolizumab alone, atezolizumab plus cobimetinib, and regorafenib. Those data are expected, I think, in the fall of this year. Until that time, TAS102 and Regorafenib are the only FDA-approved agents, and they were approved for an overall survival benefit. MSS tumors are not responsive to single-agent PD or PD-L1 blockade. There are emerging strategies which are important and should be investigated, but in clinical trials only, not as standard of care. Thanks.